Welcome to the deep dive. We are tackling quite a stack of sources today that really holds the keys to clinical diagnosis across three massive body systems. If you want the shortcut to understanding those critical signposts, the things doctors look for that immediately point to a specific pathology, this is your deep dive.
That's absolutely right. We're essentially translating some highly dense medical knowledge, specifically radiological pathology and diagnostics, into, well, a more structured overview. Our mission is to pull out the most powerful, the most memorable diagnostic signs for you. We're really hunting for those aha moments that can take a whole mess of symptoms and make them click into one specific clear condition, whether that's in bones, the gut, or the kidneys.
That sounds less like reading a textbook and more like learning maybe a secret language of x-rays and scans. Okay, let's unpack this dense stack of sources. We're starting with the structural foundation. The skeletal system.
Right. And we begin with the absolute basics of imaging. If you suspect a fracture, the crucial first step is actually often overlooked. You must obtain two projections, two pictures, as close as possible to 90 degrees to each other. If you don't get that perpendicular view, you can completely miss the actual relationship, the displacement of the fracture fragments.
That immediately clarifies why just one picture isn't enough, right?
Yeah.
You can't tell if the bone shifted forward or back just from the front. And speaking of technique, what's the technical challenge when you're trying to optimize the image quality? Because you've got dense bone right next to, well, squishy soft tissue.
Exactly. Finding that perfect balance is tough. You need enough power, enough punch to penetrate the bone, but not so much that you completely burn out the soft tissue details, things like, inflammation around it or joint swelling. The ideal kilovolt peak, the kVp range, it's surprisingly tight, 60, 69 kVp. That narrow band gives us the optimal contrast to see both bits clearly.
Okay, let's shift from technique to time, because bones are constantly changing. For a child, growth and length happens in one predictable spot, doesn't it?
Yes, absolutely. Growth occurs right at the epiphyseal cartilage, which we call the growth plate. But the source material highlights a much more, well, insidious change that's linked to aging. After age 40, we enter this dynamic phase where bone loss on the inner surface, the endosteal surface, actually starts to outpace bone gain on the outer margins.
So it's like an inside-out loss.
Precisely. It reduces the overall density and, paves the way for fragility later on.
And fragility leads us straight into inherited disorders.
Yeah.
I found this comparison really fascinating. We have two conditions causing severe fragility and fractures, but they have a complete opposite effect on bone density.
Yeah, this is a classic diagnostic paradox. On one side, you've got osteogenesis imperfecta, OI, the brittle bone disease. Radiographically, you see severe osteoporosis, thin, kind of defective cortices, and evidence of multiple healed fractures. But the really unforgettable clinical sign, the one that sticks, is non-skeletal. It's that distinctive blue tint to the sclera of the eyes, the blue sclera sign.
That is a memorable feature. And the sources mention that for patients with advanced OI, surgically placing extendable rods in the long bones is a key intervention, helps manage that constant risk of breaking.
Exactly. Now, compare that with the opposite condition, osteopetrosis. Despite causing frequent fractures and even anemia, this condition is characterized by a symmetric, generalized increase in bone density.
Increase. Wow.
Yeah, the bones are described as rock hard, almost marble-like, yet they're functionally flawed and still brittle. It really challenges that simple assumption that dense bone equals strong bone.
Okay, moving to inflammatory diseases now. Arthritis produces some really distinct imaging patterns we can't ignore. If a radiograph shows that fusiform periarticular soft tissue swelling, kind of spindle-shaped swelling around the joint alongside classic marginal erosions, what are we looking at?
That's pointing strongly towards rheumatoid arthritis, RA.
And how does RA actually destroy the joint? What's the mechanism?
It's primarily due to the formation of something called pannus. This is an abnormal layer of sort of fibrovascular tissue that grows across the joint surfaces.
Okay.
That pannus is the main destructive process. It basically chews away at the cartilage first and then the underlying bone, leading to those characteristic erosions you mentioned.
Then we have the visually dramatic ankylosing spondylitis, which gives us that famous bamboo spine.
Ah, yes. That diagnosis is often confirmed in patients who come in with chronic lower back pain and stiffness. The key radiographic feature is the bilateral and crucially symmetric involvement of the sacroiliac joints.
Symmetric, okay.
And it progresses up the spine, eventually leading to the fusion of the vertebrae, giving that bamboo-like appearance.
Wait, so symmetric involvement is the defining feature there for ankylosing spondylitis?
Yeah.
But our sources immediately contrast that with Reiter's syndrome or reactive arthritis, which involves bilateral but asymmetric sacroiliac involvement. That difference sounds like the single most crucial distinguishing clue.
It absolutely is. That's the differential diagnosis signpost right there. Asymmetry suggests a reactive process, and Reiter's often follows a recent infection, maybe gastrointestinal or genitourinary.
Right.
And just to finish off the joint pathologies quickly, remember tuberculous arthritis? There we see extensive osteoporosis near the joint juxta articular osteoporosis and late onset joint space narrowing, usually in patients with a history of pulmonary TB.
Okay.
The infection doesn't just inflame, it really eats away at the bones surrounding the joint.
That's a powerful transition from structure to, well, destruction. Let's move down the body into section 2, the digestive highway, from mouth to colon. We start again with an imaging challenge. If a patient has a site that's extra fluid in the abdomen, what does the radiographer have to adjust?
They have to increase the kilovolt peak, the kVp. Water is much denser than, say, gas or normal soft tissue.
Makes sense.
So if you increase the fluid content in the body part you're imaging, you have to increase the power to penetrate it adequately. Otherwise, the structures behind all that fluid will look washed out, or you might not see them at all.
Thinking physiologically now, the colon is the great water recycler. If a patient is suffering from constipation, what's the functional reason for the, resulting hard, difficult to pass stool?
It's a direct consequence of slow colonic transit time. Basically, the longer the fecal mass hangs out in the large intestine, the more time the colon has to aggressively reabsorb water from it. The result is stool that's dehydrated and compacted.
And connecting the digestive tract to the liver, if we see a patient with existing liver damage who's experiencing excessive bleeding or swelling, it points to the liver's failure as a major chemical factory, right?
Precisely. The liver is where key blood clotting proteins are synthesized. When the liver is damaged, its production of fibrinogen and prothrombin is impaired. That means the body just can't form clots effectively, leading to spontaneous bleeding and swelling.
Okay, now let's trace the path of food, starting with GER, that common, uncomfortable burning chest pain, often worse after fatty foods or caffeine. What's the serious complication that GER can lead to?
The serious progression is to Barrett's esophagus. This is a metaplasia, a change in cell type, where the normal squamous lining of the esophagus gets replaced by columnar epithelium, which is more like the stomach lining.
And that's considered premalignant.
It is. It's a significant premalignant change, yes.
Okay, here's a critical alert from our sources, one that every clinician really needs burned into their memory. Any patient over 40 reporting progressive difficulty swallowing dysphagia. What's the default diagnosis until proven otherwise?
You absolutely must rule out esophageal cancer. Given the seriousness and the potential for rapid progression,
Yeah.
any new worsening difficulty swallowing in that age group is an immediate red flag. It demands aggressive investigation.
We also have 2 incredible visual cues in the esophagus mentioned. First, that tapered narrowing at the distal end that looks exactly like a rat tail.
That is achalasia. It's a swallowing disorder where the lower esophageal sphincter fails to relax properly. It creates that smooth, tapered blockage.
Okay, and the second one?
Second is Zenker's diverticulum. This is an outpouching on the posterior wall of the cervical esophagus up in the neck area. Its clinical danger is that it acts like a little pouch that traps food, making the patient highly susceptible to aspiration pneumonia. Food goes down the wrong way.
Right. Aspiration. Let's ramp up the intensity now and move to acute abdominal emergencies. This is where imaging can be life or death. What is the classic, absolutely unmistakable sign of a perforated viscous hole in the bowel or stomach?
It's the presence of free air under the diaphragm. On an X-ray, you're looking for a sickle-shaped lucency, like a black crescent, right underneath the diaphragm muscle. That's pneumoperitoneum.
And positioning is key here.
Crucial. Because air rises, you have to position the patient upright, if possible. If they absolutely can't stand, then you use the left lateral decubitus position. Laying them on their left side allows the air to collect visibly over the liver, away from the natural stomach bubble on the left.
Those are critical positioning details. We also have 2 pediatric diagnostic signs that are truly iconic. First, the 3-week-old infant with projectile vomiting and a palpable mass.
Ah, yes, that's pyloric stenosis. The physical finding is often described classically as a mobile hard olive in the upper abdomen.
An olive.
Yeah, that's the description. And the ultrasound confirms it by showing a markedly thickened pyloric muscle, typically thicker than 3 millimeters. That olive sign is pretty much a dead giveaway.
And the second pediatric alert, common in maybe 2-year-olds with intermittent severe abdominal pain, the target or donut sign.
That immediately points to intussusception. That's where the bowel telescopes into itself. That circular, target-like image on ultrasound is the key. Interestingly, the presentation can look different in adults. If you do a contrast study, it often shows up as a coiled spring appearance, where the barium gets trapped in those telescoped layers.
Okay. One final point on the digestive tract before we move on. We noted the liver's massive importance. Which viral culprit is most commonly associated with chronic liver failure and is now the principal cause of liver transplantation in the U.S.?
That would be hepatitis C. Its relentless progression to chronic hepatitis, then cirrhosis, and ultimately hepatocellular carcinoma makes it a leading cause of end-stage liver disease, not just in the U.S., but globally.
All right, moving swiftly now to our final section, the renal filtration system. Let's start with just the marvel of kidney function. How much water does the kidney actually filter every day, and how much of that gets excreted?
It's an incredible metabolic feat, really. The kidneys filter approximately 190 liters of water out of the glomerular blood daily.
190 liters?
Yeah, it's huge. But a healthy person typically excretes only about 1 to 2 liters as urine. The vast majority, over 99%, is recovered by the body.
And what are the twin hormonal regulators that manage that really precise recovery of water and sodium?
That would be antidiuretic hormone, ADH, and aldosterone. They are the master volume and pressure regulators for the body.
Our sources gave a great example of the kidney's role in balancing body chemistry. If blood pH gets too acidic, say 7.3, how does the kidney rapidly respond?
It responds by actively excreting an acid urine. It's basically pumping out excess hydrogen ions, H plus A, to bring the pH back up.
Okay.
This really highlights the kidney's critical role beyond just filtration maintaining homeostasis. Conversely, if the system fails, if the glomerular filtration rate, the GFR, drops, the direct consequence is a buildup of waste products. We measure that as increased BUN and creatinine levels in the blood.
Let's talk structural issues. Describe the classic congenital anomaly known as the horseshoe kidney.
Okay. In this anomaly, both kidneys are positioned lower than usual in the abdomen, and they're actually joined together at their lower poles, forming a U or horseshoe shape.
And the significance isn't just the shape.
No, the clinical significance is often related to drainage. The abnormal insertion of the ureters, the tubes draining the kidneys, can lead to inefficient urine flow. This, in turn, makes this condition particularly prone to the formation of kidney stones.
Okay. Contrast that structural flaw with what happens in unilateral renal agenesis, the absence of one kidney from birth. The remaining kidney compensates dramatically, doesn't it?
Absolutely. That phenomenon is called compensatory hypertrophy. The one existing kidney actually becomes larger than normal because it has to take on the full workload of filtering the blood.
We also noted a specific pediatric obstruction, posterior urethral valves. How is that diagnosed?
Right. That's typically picked up with a voiding cystourethrogram, or VCUG. This study reveals it as a narrow point in the urethra, the tube from the bladder out, caused by a thin membrane blocking the flow. It's a key cause of urinary obstruction in male infants.
Okay, finally, let's touch on infections and inflammation. Pyelonephritis is a serious kidney infection. What are the clinical and microscopic clues we absolutely need to see?
Clinically, you're looking for high fever, chills, significant back or flank pain, and the urinalysis will be loaded with pus, that's called pyuria, and characteristic white blood cell casts.
Casts, right.
Imaging, like a CT, often shows patchy inflammation within the kidney tissue itself, the parenchyma. And it's serious enough that pregnant women who develop pyelonephritis nearly always require IV antibiotics and hospitalization.
How does that look different from acute glomerulonephritis?
Glomerulonephritis often presents differently. It might be suggested by blood in the urine, hematuria, and decreased urine output, frequently occurring after something like an upper respiratory infection.
Okay.
And imaging reveals a key distinction. Typically, you see bilateral small kidneys with smooth contours. This points to inflammation and damage primarily affecting the glomeruli, the tiny filters themselves, rather than the broader kidney tissue like in pyelonephritis.
And for the classic kidney stone urinary calculi, the symptom is that undeniable severe radiating pain, often from the kidney area down towards the groin. Which imaging modality really nails the diagnosis?
Non-contrast helical CT. It's considered the gold standard.
Why non-contrast?
Because it can definitively identify even small, dense stones and show any resulting blockage or swelling of the ureter without needing intravenous contrast dye. Using contrast might be risky if kidney function is already potentially compromised by the stone.
Got it. We end with one last vital visual distinction: the difference between a benign fluid-filled mass and a potentially malignant tumor in the kidney.
Right. On imaging, a benign renal cyst has really textbook features. A perfectly smooth, thin, often radiopaque rim around a lucent, clearly fluid-filled structure. Sometimes there's a little point where it meets the kidney called the beak sign.
Okay, smooth and thin.
Exactly. But if you see irregular, shaggy, or thick borders around a mass, that is a massive red flag suggesting potential carcinoma. The
Mhm.
quality of that margin, its purity, is absolutely critical for differentiating benign from suspicious.
Wow. We have covered an incredible amount of ground today,
Hmm.
identifying these really distinct signposts across the body, from, that subtle interbone loss that marks aging after 40,
Mm-hmm.
to the life-threatening sickle-shaped lucency of free air in the abdomen, and the incredibly complex function and potential failures of a single kidney.
Yeah, the real power of these sources, I think, is in showing us that pathology translates directly into these highly specific, often visual signposts. That dense medical knowledge can actually be distilled into these precise markers. The knowledge that a bamboo spine means symmetry, or that a mobile hard olive immediately targets a specific diagnosis. Well, that's true diagnostic efficiency.
That really is the deep dive payoff. And as we close, let's leave you with this provocative thought. We focused heavily today on conditions that cause critical failure. Things like needing a liver transplant, having a severely reduced GFR, major fractures. But if the body filters a massive 190 liters of fluid every single day, what is the first leader telling us when something is starting to go wrong? What are the really subtle signs of inflammation and disease we might be able to identify before we reach those clear-cut, often catastrophic failure points?
Keep seeking those early markers. It's worth thinking about.
Indeed. We'll see you on the next deep dive.